I think Siteman is actually one of a kind. In the United States today, you probably can get excellent care at maybe 15 to 20 centers for head and neck cancer. But what the difference is the multidisciplinary aspect of it, I think, is very special here. The fact that we have a team that works really well together. Every patient gets presented at tumor board, gets discussed by about 10 different physicians across all the different specialties so that every patient is ensured to get consistent but also excellent care. But the other thing is really the clinical trials. So here at Siteman, we put more patients on trial than many, many other centers, and this is in part due to the leadership of the medical oncologists, radiation oncologists, and surgeons, and the feeling on behalf of all three parts of the team that this is incredibly important to not only advance the clinical treatment of patients, but also to actually find new ways of doing better in terms of head and neck cancer treatment. Every time we remove a tumor with the patient's permission, we'll actually get a piece of that and send it to the lab. And we're doing, advanced genomic analyses and things like that that tell us actually what's going on in each individual patient's tumor that will allow us to actually develop new treatments and cures that will be the next generation of treatment. And so it's the combination of those three things that I think really sets us apart. I think here at Washington University, the collaboration with the Siteman Cancer Center and Barnes-Jewish Hospital is honestly one of a kind. And actually, I think that starts in the most basic level with the fact that we're actually co-localized. So in many different centers, the hospital might be located 10, 15, even 30 miles away from the actual research institutes. Here, patient tumors are going from the operating room, from the clinic, directly to the lab within minutes, enabling us to actually analyze tumors in ways that aren't possible when we're physically separated. In addition to that, the fact that the med school has such a large research presence allows one to sort of engage in meaningful translational research, because when research labs, even dedicated researchers, are embedded in the med school campus, there's this sort of indelible imprint that happens where people are naturally inclined to pursue questions related to human health and patient care. And as a result, on the med school campus, you find a lot more research projects that are more patient-oriented, more focused on new treatment, more focused on understanding disease than you would on a campus that might not have a med school. So I really think head and neck is at the forefront of surgical innovation. The two biggest changes, I would say, from a surgical perspective that have really changed the way we treat patients are, first of all, the use of free tissue reconstruction. Now, when a patient has head and neck cancer that involves their tongue, their jaw, their throat, we can actually borrow tissue from somewhere else in the body, the arm, the leg, the back, the stomach, different places, and we can actually fill in the tissue that's missing. So for example, we might have a patient with a tumor of the jaw. We actually borrow tissue from the fibula, which is a bone on the side of the leg. We actually fill in the missing part of the jaw with the patient's own bone, so there's no sort of issue of rejection or anything. But the way I like to explain it to patients is we're basically transplanting your own tissue to a different part of your body. And then we connect the artery and vein that keep that tissue alive normally in the leg or the arm or the back to an artery and vein in the neck that then keep the tissue alive. So we do this all with a suture that's the size of a human hair to bring the two arteries together and the two veins together. And believe it or not, sounds crazy, but we have a 97% success rate doing this. And so because of these innovations in surgery, which are now, these are surgeries that 15 years ago used to go 24 hours in length. We're able to finish these surgeries in about 8 to 9 hours, and sometimes even as little as 4. And so this has been an absolute game changer in terms of how we think about patients and reconstruction. The other major innovation is the use of robotic surgery. In the past, if you had a tumor in the back of the throat, and this would primarily in today's age be a tumor that's related to human papillomavirus or HPV, to get to that back of the throat, we would actually have to split the jaw and open the patient's jaw like a book, really, to get to the back. So you can imagine that the healing from that process was not insignificant, and many patients, got through the surgery, but then ended up not being able to swallow or have real function. Today, we're able to use a robot that's actually controlled with a console about 20 feet away from the patient. The surgeon's still in the room, don't worry. And we bring the robot in and we actually work through the patient's mouth with a high definition camera, 2 small arms that actually move in a way that I can't move my hands because they're too large to fit in a patient's mouth, and then cut out the edges of the tumor under direct visualization. And as a result, we don't have to split the jaw. Patients are able to swallow sometimes the very same day, if not the next day. And oftentimes they're leaving just 2 or 3 days after the operation, more or less completely normal. And so it's these two things that have really completely revolutionized the way that we think about head and neck surgery and have been massive changes in the way that we approach patients. Gone is the era of paternalistic medicine where a patient comes in and we say, this is the treatment, we'll see you next Friday, pack a bag for a week and, we'll take care of the rest. That's really not how medicine is practiced, and I think for a good reason. every decision a patient makes about their health, whether it's related to cancer or not, has consequences. Some may be positive, some may be negative. But ultimately, our job as physicians is to make sure that patients have the information to make the decision that is best for them and their family. The same tumor in the exact same location might be treated very differently for a patient that has tons of support versus a patient with no support. Might be treated differently for a patient with a history of radiation versus a patient without a history of radiation. Might be different for a patient that has the ability to actually go to their radiation oncologist every day for 6 weeks versus one who might not. And so to ignore the realities of life, the realities that patients face, in my mind is sort of very closed-minded and misses the whole point of being a doctor. The whole point of being a doctor is to give patients the power to understand their situation, understand their options, talk them through the pros and cons, the risks and benefits of every one of these options, and then to make the decision that's best for them.